Thank you, thank you. So good morning, everybody. It's good to see so many familiar faces here. And I'm going to talk a little bit about the post-traumatic stress disorder. And let me ask you this way. Anyone here has not treated or seen a patient with the post-traumatic stress disorder? Okay, few people. But majority of you have seen post-traumatic stress disorder, patients you have evaluated, patients you have treated. But in spite of all this, this is still a most unrecognized sometimes and undertreated disorder. So we're going to talk about it, and we'll talk a little bit about the neurobiology of it. So we will talk about the epidemiology of the PTSD, risk factors, and we'll conceptualize it as a psycho-neurobiological disorder. Then we will have a brief overview with the DSM-V. So what has changed from DSM-4 to 5? Then we'll talk about the treatment. You can look at any studies done in the last 40 years. The lifetime prevalence is 8%. In all these studies, it's come about 8%. But if you look at what type of trauma, is this a trauma itself, or is this a person, they are vulnerable for the PTSD? But the type of trauma which is common in women, which will cause the PTSD, like rape. In men, it's combat. But the people who develop the PTSD, in about 1/3, it's about 30% of the patient will have a chronic disorder. It persists for years, and it causes a lot of disability. And many of these patients, almost 88% in these various studies, also have psychiatric comorbidities. So PTSD is not alone. If you have a patient who has multiple complaints and multiple type of disorders you are thinking about, think about the PTSD underlying. Okay. So likelihood of getting PTSD, if you experience a trauma, is this just the trauma itself, or is this a person? So it depends on both. It depends upon that event, what happened. It depends upon the person. In the case of men, it's mostly they are the one who have more traumatic events, but only about 8% of the men get the PTSD. So if it's a trauma alone, then it should produce more PTSD. In women, the trauma is less, but they develop more PTSD. So there is a role of the gender in developing the PTSD. So we know that in the combats, the PTSD is common. But even in the combats, you look at the different one. You look at the Vietnam War, and you look at veterans from that war, it's about 30% had the lifetime prevalence. And if you look at the Gulf War, it was between 5 to 10%. And then the Operation Iraqi Freedom and the Enduring Freedoms is 10 to 20%. So why that's a difference? So it depends again what type of war is that, what type of sport the people have back home, and what do they see in the combat. So what's the likelihood of getting the trauma after various events? Rape is one of the trauma which lead to PTSD. But if there's a difference in the gender, if you look at the men, it's more common PTSD. It's about 65% of the men will develop the PTSD. In the women, it's about 45%. So in combat, it's about 40% in the men. And the physical abuse, it's mostly more common in women. So it depends what type of trauma is, there is a role of the genders, there is a difference between the genders. So the risk of developing the PTSD is going to depend what kind of social support person have and what is the degree of the life stress the person is going through. So it's not just the event itself, there are so many other things which are present at the time. So what put people at risk? If you are being a female, that's a risk factor, being poor, less education, having a bad childhood, or any previous psychological problems person have. So then also it can depend upon the severity of trauma. What happened in the trauma, how long it lasts, it caused any kind of injury, or is there any loss of any body parts. Any history of prior trauma? There is also a role of the race. Ethnicity has a role in that. In Latinos, it's higher. If there is previous history of any mood disorder, anxiety disorder, or there is a family history of mood disorder, anxiety disorder, that puts the person at risk. So also the trauma, the strength of the stressor is how the person perceives what's going to happen at that time. The perception of the life threat is going to be higher. What type of feeling it brings? Is a feeling of helplessness, feeling unpredictable, uncontrollable. Remember in DSM-4, this was the second part of the diagnosis. The person had experienced a threat, and what was the person's reaction to that threat. But in DSM-5, this part has been removed. But that does not mean the person doesn't have it. What happens is when they do the research, people have PTSD for many, many years, and they sometimes forget what they really had at that time, what they had the feelings. So they cannot describe it. So that leads to the misdiagnosis, basically. But the more person feel helpless at the time of the event, and that's going to produce trauma. We'll talk about it, what's the underlying neurobiology of that. So if you look back at the last 5, 6 slides, so remember 2, 3 things. It's common. Lifetime prevalence is 8%. It's more common in women as compared to the men, even though the men experience more traumatic events as compared to the women. Okay. So let's talk a little bit about this part. What happened underlying in the neuroanatomy and neurobiology? So remember your time from the school with some of the neurochemistry, we'll talk about it. But main thing is, remember these 3, 4 things. They are part of this area called fear circuit. And part of that is the prefrontal cortex, this hippocampus, amygdala, hypothalamus. So there is a loop between the cortex, thalamic, striatal, and the amygdala. This loop gets activated, and when that's activated, that produces tremendous amount of fear. So that's what we're going to talk about. We'll talk about what happened with the underlying neurobiology. So this is a neuroanatomy. So the area to remember is hippocampus, amygdala, and the prefrontal cortex. So what happened? Remember the hypothalamus and the pituitary. The hypothalamus secretes various kind of hormones. And one of the hormones which is related to the PTSD is called CRF. It's corticotropin releasing factor, CRF. So what happens is these are the neurons in the hypothalamus. Under stress, they secrete CRF. Some of that will go into the bloodstream, the other one directly travel to the pituitary. So CRF produce various kind of further down the road cascades. So what happens is CRH is produced in the hypothalamus. It goes to the pituitary, and the pituitary start to release this ACTH. And that, through the bloodstream, go to the adrenal glands. That's near the kidneys. And from there, it secretes cortisol, and that travel back, and it gives a negative feedback. So that's enough, so there is no need to produce anymore. Okay. So the other way to look at this, so the hypothalamus release corticotropin releasing hormone that go to the anterior pituitary, that release the adrenocorticotropic hormone ACTH, and that go to the adrenal cortex, and that release cortisol, and that give negative feedback, and that cut down the production of the CRH and the ACTH. So in that way, the body keep the cortisol under control.
What do you mean by negative?
Negative feedback is when the level rise, that stop the production of the CRH. Okay. So otherwise, if the level does not rise enough, the hypothalamus neuron, they will continue to produce the CRH. Okay. And if they continue to produce, it's going to increase this cortisol. And what happens when the cortisol stay up? Blood sugar go up, and it start to metabolize the fat and the carbohydrates, and it also affects the neurons in the hypothalamus and these areas where it produces further changes. We'll talk about those, what happened with those changes. So there is a difference in the person who is going to develop the PTSD. This is what we really are learning. This is an interesting type of the research going on. One more now. If you look at in the patient who are going to develop the PTSD, they have persistently low cortisol. But if you look at the other condition like depression, panic attacks, anxiety disorder, they do not have that kind of profile. That profile is seen mainly in the patients who have PTSD. So what that means is, when you have a low cortisol to begin with, the negative feedback is not there. So the hypothalamus is going to secrete more of the CRH, the corticotropin releasing hormone. So it tries to compensate by increasing the cortisol. So what happened at the time of the trauma, when the acute thing is going on, the cortisol level in this person is low, body is producing more CRH, and it tries to increase the cortisol. That's the acute part. But what happens is when it keeps doing it, so chronically, the person is going to have hypercortisolemia. So ultimately, underlying from the pituitary and the adrenal gland, they are going to produce of the cortisol. So its body is going to compensate that. So what happens is when you have so much elevated cortisol, it starts to affect the neurons in the hippocampus and the amygdala. So what happens in the hippocampus is, if you have that much level of the cortisol persistently higher, you're going to have a neurotrophy. What that means is the volume of the hippocampus is going to shrink. it's going to get smaller and smaller. And if it stays smaller in the long run, it does not recover. There are various kinds of studies done in the kids, who were abused sexually, emotionally, physically. And if you look at them and you follow them for over a period of time, like maybe 20, 30 years, you will see their volume of the hippocampus is very small. Okay. So what it does is, the brain there is ongoing neurogenesis. The brain neurons, they produce the dendrites, and the dendrites spreads into the spine, dendrite spine. And under the persistent high level of the hypercortisolemia, those dendrites, they shrink. It does not produce those dendrites and those dendrite spines. So that is the consequences of the hypercortisolemia. So there are all kinds of studies going on at this time. Under the acute stage, when the cortisol level is low, can you give something to somebody and prevent the PTSD? So there are studies which are right at that time you give hydrocortisone. When the person has experienced a trauma, if you see them within 24, 48 hours, you give them hydrocortisone to bring the cortisol level up to stop the CRH. And then you can prevent the PTSD down the road. Okay. The second part of the studies are going on. Remember that CRH has receptors in the brain in the areas where it causes the decrease in the dendrites. So there is at this time, some medicines are used to block those receptors so it does not produce this cascade. They are called CRH antagonists. So there is a research going on there. It's again in the acute stage. All these things are more important right in the acute stage. So either give hydrocortisone or give CRH antagonist to block it. Okay. Any question about the CRH or cortisol? Okay. So cortisol is it's a normal hormone which we all need. It comes in a circadian rhythm. When we get up in the morning, the cortisol level is higher. Then it starts dropping during the day. Same thing with the exercise, those things will produce the cortisol. Anybody have heard this stuff called neuropeptide Y? There is a lot of research on neuropeptide Y. It is one of those peptides which are produced by the pancreas, and it's also produced in the brain. And what we are looking at is the action of this neuropeptide Y in the hippocampus and the amygdala. So 5 receptors has been identified from there called Y1 to Y5. So Y1 and Y2 has a role in this anxiety and the PTSD. So what happened to this neuropeptide Y system in the stress, anxiety, and depression? If the NPY system is inactivated or not functioning well at that time, there is increased emotionality. So there will be opposite effect of that. If there is a neuropeptide Y is overactive, person is calm and is less anxious. So that's the role of the neuropeptide Y in the body. And in the case of PTSD, we are looking at again the amygdala and the hippocampus. And there is some evidence in the other area, locus ceruleus. So we'll talk about that part in a few minutes. So at this time, if you can give something like agonist is produce the action of that at the receptor, you can lead to the anti-stress, anti-anxiety type of effect. Or you can give the blockade, the white-2 receptors, and that will produce the anti-stress and the anti-anxiety effect. So this is what's happening in the body with the neuropeptide Y. Okay. But then there's a relationship between the NPY and the corticotropin releasing factor. So we talked a little bit earlier what happened with this CRF. If the level is increased, it produces the anxiety. The NPI, if the level is increased, it produces a decrease in the anxiety. And this balance is created in this part of the brain called BNSD. It's in the brainstem, bed nucleus of the stria terminalis, where the scale is. If the scale tilts towards the CRF, it produces the anxiety. If the scale tilts towards the NPY, it causes less anxiety. Okay. Any question about that? But again, in the research, if we find some medications, there are some which are in the investigation stages going on at this time. If we give the agonist is like, let's say, what type of medicine we have which is agonist for anxiety at this time? It's called Buspar. Okay. Buspar is an agonist at the 5-HT1A. It's a serotonin receptor 1 where it's agonist. And if we act on the agonist, we can reduce the anxiety. So that's the role. Same way NPY, agonist and antagonist are being looked at as a part of the anti-anxiety. It's again giving right at the time of the trauma, and the NPY, if we can find something that can be used later on. Yeah.
So are you saying that they should be prepared, say, like on the battlefield when there was a traumatic event, to just as a safeguard to
Yeah.
do this to kind of
Right.
neutralize the same thing with rape victims in a hospital?
Right.
And then this will prevent this long-term chronic condition.
That's the theory behind it. So that's what the research is at this time. I think that you are familiar with all this area. You are familiar with the norepinephrine, serotonin, dopamine. This is what all of our patients come and talk with us. I have some chemical imbalance. So that's what they are talking about. So there is something going on in this chemical imbalance. And we are familiar with this serotonin role because we have so many of these antidepressants which we use, which work on that receptors. And in the depression, anxiety, we are familiar with the norepinephrine role because if you look at all the panic attacks and the fight, flight type of stuff, that's all norepinephrine type of thing. The dopamine is a player type of chemical. And so in the case of the PTSD, there is a role of the serotonin, there is a role of the norepinephrine. And the dopamine has a little bit role, but not as the serotonin and the norepinephrine. All of the norepinephrine in the central nervous system is in this one little area. It's called local soleus. Same thing is in the serotonin. It's in this nuclei called Raphe nuclei. And then the dopamine is in this area called ventral tegmental area. So it's a release from here. Then it travels to these areas where it causes different things. Dopamine, when it acts on the nucleus accumbens, it's like a reward type of chemical. That's what happens is, if somebody is using drug, like let's say cocaine, what are they looking from it? They just want to increase the dopamine in this area, nucleus accumbens. So remember, these are the areas which will be producing it, and there is a role of the locus coeruleus in the PTSD. So we'll talk a little bit about it. So norepinephrine, it's produced in the same type of neuron where dopamine is produced, but there is a little difference in it. Dopamine is produced in the same neuron, and the dopamine is further converted into norepinephrine. Then it's released where it acts on the postsynaptic receptors, then travel right back into the neurons. So there is a role of norepinephrine peripherally and centrally in the brain. Peripherally, what happens when the norepinephrine level goes up? So what happens in stress? Right under the stress, immediately the body produces norepinephrine. And it happened right in this area, locus coeruleus we talked about, and some of the other peripheral sympathetic nerve terminals. Then what happened to that? If it's in the periphery, it's going to increase the blood pressure, it's going to increase the heart rate, tachycardia, hypertension, hyperventilation, and so what happened with the central part? So it's the feeling of this restlessness. So this is a part which is part immediately at the time of the trauma. There is an increased level of norepinephrine. So what happens when you have high levels of norepinephrine in those areas which we talked about, the hippocampus and the amygdala, especially in the amygdala, that's where the fear center is. So immediately body recognizes there is something going on. I need to do something about it. Okay. So there are studies going on at this time again. Remember this blood pressure medicine, propranolol, Inderol? If right at the time of that trauma you are given the propranolol, it reduces some of the PTSD symptoms. It may not prevent it. It will reduce the severity of it. It reduces the long-term consequences of it. It may not be as severe. That's the advantage of that. So the other systems which are involved, they are this glutamate system and the GABA system. The GABA is where the benzodiazepine and the phenobarb type of medicine work. They work through this GABA system. If you have more GABA, it's a stress releasing type of thing. And that's why the benzodiazepine, when they act on this receptor, they enhance the effect of the GABA, and that lead to the benefit in the anxiety. Benzodiazepine have a role, but in the long term, it really do not produce much benefit. But right at the time when the stress is happening, it can be helpful at that time. And that comes through the GABA system. The opposite of that is the glutamate system. The glutamate, if it's overactivated, it's a toxic. And the elevated levels of the glutamate can lead to, again, the same thing which we talked earlier. That is cause the atrophy of those neurons, dendrites. And also, if it's too elevated, it can lead to the seizures and those kind of things. So that is the role at that time. Some of the medicines which can used as an antagonist, which can block the effect of this, that can prevent those things. So there is a research going on that part. Anybody heard this one, ghrelin? Okay. There is a lot of research going on in the ghrelin and other peptide like that. Like neuropeptide, this ghrelin is produced actually in the stomach, and it increases the appetite. It has a role in the appetite. It's secreted here right in the fundus of the stomach. Okay. And in all these parietal cells in this area, that's where this peptide is secreted. And then it's released, and when it goes to the other part of the body and travel, let's say, to the brain, it cannot cross this blood-brain barrier. Okay. So when it goes to the brain, it has to cross this capillary, that is the arteries, and then it has to go through that to the layers to go into the neurons. But that's not possible many times. You cannot cross. So what it does is basically it travels from there right through the nerves back to this area, hypothalamus. Okay? And what it does is, so what's the role of this ghrelin in the stress? So it's a peptide hormone. Basically, it makes the person vulnerable to the increased fear, learning, and this action occurs in this amygdala, which we are talking about. So see how many neurobiological, either the hormones or the neurotransmitters or these peptides have a role in the anxiety. But then they have to be balanced somewhere. So what happened with that? So here is what we have talked about in the stress on the brain. This area called hippocampus, we talked about the amygdala and the prefrontal cortex. We talked about the CRF. It's produced in the hypothalamus. Its effect on the hippocampus and the effect of the locus coeruleus norepinephrine on the hippocampus. If the person have elevated levels of the norepinephrine at the same time and the elevated level of the CRF and the decrease in the neuropeptide Y, so what will happen? It's some of that is the immediate effect, the long-term effect. The immediate effect in the under the time when the stress is happening, the body keep increasing the corticotropin releasing factor and the norepinephrine stay elevated. What it does, it starts to increase this volume of the amygdala. It becomes larger. And it starts to decrease the hippocampus, and that becomes smaller. Okay. So what is the role of the hippocampus? The role of the hippocampus is in the memories. That's where we remember all this thing. That's where the encoding of the memories happen. Okay. What's the role of the amygdala? It's mainly dealing with all our emotions. It's the fear, the rage, anger, all these things are in this area, amygdala. Okay. So when the trauma happens, the memories are encoded. And they are encoded based on this fear factor, because the amygdala is producing all this fear. So the context of those memory is what? This is a fear and this is a trauma. So it all become conditioned. So it's a conditioned response of that fear which is encoded in there, in this hippocampus. So how you can extinct it? You need to have this prefrontal cortex. And the prefrontal cortex is the one where we have all these cognitive functions, how we plan things, how we organize things, how we sequence things, and how we carry on those things. This is all in the prefrontal cortex. And in this part of the cortex, which we call cingulate cortex, anterior part of that is called ACC. In PTSD, that area also becomes smaller. So what happens is, that part of the brain in this cortex, prefrontal cortex, which can help us to extinct those memories, is not functioning as well at that time. So in PTSD, this part of in the prefrontal cortex, it's smaller due to all the effect of things which we talked about. The amygdala is becoming larger, its volume has increased. So that is where all the fear conditioning, so it's not getting extinct. And then the hippocampus, the context is even the trauma itself or the non-trauma type of things can induce all those memories. So what happened with the PTSD person? Remember, they start to avoid things. And because some of those things, they bring the memories and produce some psychological and the physiological reaction to that. And that's related to all this circuit. Okay. So what happened? If you look in the scans and look under the magnetic resonance spectroscopy, you are going to see this part of the brain we are talking about is the hippocampus. The volume of this is going to get smaller. Amygdala, the volume gets larger. And this part in the prefrontal cortex called anterior cingulate cortex, this is a cingulate, anterior cingulate, it's called, we can call ACC, anterior cingulate cortex. This area gets smaller. And it has been repeated in multiple studies in patients with the PTSD. And in chronic PTSD, this is what happens. So that's the reason all that other research is going on to find something which we can treat early to prevent this effect on this area of the hippocampus and the amygdala. Okay. So there is a role of the immune system in that also. There are some studies going on there. And there is just one study which came out this week. So what did they do was, they took some mouse, and they, all male mouse, and they kept them together from little ones. And so what happened? There is a hierarchy. So there is alpha male, ultimately developed. So they have this hierarchy. Then suddenly they bring another rat, which is not part of this colony, and which is very aggressive rat. And they put that rat in the middle of that. And they keep that rat there for maybe, let's say, 2 hours. And then they draw all the blood of those rats. And then they repeat the same thing for 2 weeks. So during the day, they will bring that rat, and they will take it. And then they don't do that for a period of time. Then after, let's say, 5-6 months, they bring the same thing, same rat in the same colony, and see what happened after that. Okay. Then they have the other rats, who never were exposed to that type of thing. They bring all them together and bring the aggressive rat in there, and they draw the blood in those. So what happened is what they're looking at is basically how the PTSD develop in the animals. So they look at this immune system, and in the rats who were together, and then they were exposed to this aggressive rat, they start to develop this monocyte. Their level goes way high up. And then after some time, they don't expose them. Then after 6 months, when they expose them again, and then they again start to have all the PTSD symptoms. And what they do is, the animal, they store their monocyte in the spleen, and immediately on the introduction of that, it increased the level of that. So that is the research just came out in this week. So there are all kind of studies going on. Again, in the end, one day, we're going to find something which we will use right in the beginning. So what we have available at this time in the acute, we have the propranolol. So if somebody is going through that, and we can give that, and then the hydrocortisone is available, so that can be used. So there is some which is available. The other things are in the experimental stages going on. So this is the fear. Go ahead.
A question, which is, things can diffuse the onset or make it less severe, what about prevention? So, for example, have there been studies that look at differential outcomes if somebody is taking SSRI before going in? Will the potential for prevention of PTSD be?
Yes, yes. There are studies done on that. And some of that, we'll talk in a few minutes. But what it is, the studies have been done. It's very hard to get the approval in the states from the IRBs and the ethical boards that person does not have the symptoms and how you're going to treat them for long term. Okay. But there is studies done in the rest of the world. There is a study in the Israel where they looked at the kids who are physically, sexually, emotionally abused, okay, as young kids. And they gave them the SSRIs for long term. And then they have this comparative kids who were also abused, and they didn't give them the SSRI. And then they did that studies where they looked at the volume of the hippocampus and the volume of the amygdala, and they did not see any shrinkage of the hippocampus in those kids. So that is a long-term studies, and this is well-documented studies where the SSRI can prevent that. What happened is, there is if you don't have that, if you have brain-derived neurotrophic factor, it's called BDNF. The BDNF is like a fertilizer to the grass. If, what happens when we put fertilizer? The grass starts to grow. Same thing if you give the BDNF in the neurons, the dendrites, they start to sprout. Okay. So at this time, with the way we can increase the BDNF is either through the SSRIs or we can cut down some other cortisol type of thing. The medicine which I work on through the CRF cortisol, they have a lot of side effects. And because an excessive cortisol is not good for the body, it can produce like a Cushing syndromes. And but the SSRIs, for the long terms, it has been found beneficial. And but the part is ethically here how we can do the studies with that. But if we use in those patients who are developing some symptoms, it can prevent the long-term consequences of that.
How does any of these medicines or experiments help somebody in our situation where we get people that have experienced these traumas years ago and continued, and so their hypothalamus has shrunk?
Right.
Can we give them anything that will unshrink it?
Yeah.
20, 30, 40 years later?
It's a challenge, but it can be done. It's various part of this, like neuropeptide Y type of thing that are being looked at, which has a role in it. And on the other one is we have these SSRI which has roles in it. So the medicine has a role, but the medicine alone is not the only thing which can increase. If you can do some of the other psychological type of treatments which can help with the when you are increasing these dendrites, that what we call is a neurogenesis. And the neurogenesis means the brain is producing, the axons are producing the dendrites and those spines. That is increasing the volume, and that's what's called neurogenesis. And there are things which can be done for that. It's not, part of that is the medication, part is some psychological treatments which can lead to that. We'll talk about those. And there is actually a chemical which they identify, it's called VGF. It's a vascular growth factor. And it's VGF, vascular growth factor, and that can lead to the neurogenesis. So there are various kind of studies going in there. But looking at this, fear circuit. If you look at the amygdala, this is what we have been talking about. Its role is the detection of the threat and the fear conditioning. So under the trauma and the trauma-related memories, there is an increased activation of that. But what happens is when the volume starts to go up and all that norepinephrine is high and this cortisol is high, even the non-trauma related stimuli lead to the increased activations. So that leads to the severity of the PTSD symptoms. So the prefrontal cortex, which we talked about, its role is the extinction. What that means is the person is learning the stimuli are no longer aversive. So what happens with the ACC is the volume is decreasing. So, but if you can keep that up, you can have diminished activation. Okay. So the hippocampus role is the encoding of the memory and basically relates to the context during the fear conditioning. But in the PTSD chronically, it leads to the lower hippocampal volumes. But is this the only thing which is causing the PTSD? You know, not the biology alone, but there are many other factors. And those can be, we can look at various dimensions. We can look at the psychological dimension. Either the person has a pre-existing anxiety, depression, or they are having low cognitive functioning to begin with sometime, or how they interpret the meaningfulness of the trauma. Okay. Or there is a role of the social dimension. Is there any history of neglect and the abuse in the child and the person history? And if there is, that person is more prone for it. If there is lack of social support or social isolation, that also increase to the possibility of PTSD. Then there are socio-cultural dimensions. Low socioeconomic status can lead to that. We talked about the gender difference, immigration, and we already talked about all the biological dimension. What was the role of the hypothalamic pituitary adrenal axis? We talked about the hippocampus atrophy and with the high level of the norepinephrine and the CRF that lead to sensitization of these neural circuits. Okay, let's go ahead with the second part. Any questions about the part where we ended? We talked about the prevalence, we talked about the risk factors and the neurobiology, and we talked about the various dimensions. So, anybody has any?
I was wondering about the prefrontal shrinkage that you talked about. Is that going to lead to some cognition issues when you were talking about? I thought I heard you say something about some shrinkage
Right.
that would occur in the prefrontal cortex.
It's in the part. It's part of the prefrontal cortex called the ACC, anterior cingulate cortex.
Okay.
So there is some decrease in the volume that part. Okay.
Okay.
So let's, so it takes time to learn it, then they change it frequently. So it took us a while to figure out DSM-4. Now we have to deal with the DSM-5. But what really have changed in the DSM-5? Okay, not really much. So we'll talk about that. So all of you must have heard they moved the PTSD out of the anxiety disorder. It used to be a part of the anxiety disorder, but it has been removed from that section, and it has its own section called trauma and the stress-related disorders. Okay. So in the past, it was part of the panic disorder, OCD, and all of that together, phobias. So it has been removed from that section, and it has its own section of the trauma, stress-related disorders. And the type of thing under that, that heading is like adjustment disorder, like PTSD, acute stress disorder, reactive attachment disorder, those kind of things from the childhood onwards. So what changed in the PTSD itself in the diagnosis? Remember we were talking about this fear, helplessness, horror, that has been removed. So in DSM-4, that person has experienced a stressful event or witnessed an event. And as a result of that, there is a reaction to that. And that was this fear, helplessness, horror. So that part is removed. So the second part, what has changed in the past, had something like that unexpected death of the family, closer friend, due to the natural cause, that has been removed from that. Okay. All the other are the same. So remember in the DSM-4, there were 3 clusters. Those 3 clusters were re-experiencing the trauma, avoidance, and the hyperarousal. Those were the 3 main headings. And there were symptoms under those which person have to meet. And that has been changed. Now, instead of 3, there are 4 clusters. And their names are like this: intrusion, and that is intrusion of those thoughts, intrusive memories, and those are part of under in that. Then there is avoidance. People don't want to talk about it, remember? So those kind of things are under the avoidance. Then there is a heading of negative alterations in cognition and mood. And that is what person feel, experience. And then alternation in the arousal and the reactivity. These are the 4 headings under which you have to meet those symptoms. Then this new subtype is added to it. It's the dissociative symptoms. So what type of dissociative symptoms you see in the PTSD? Anybody have any idea what you will call a dissociative phenomena in a PTSD? Flashbacks, yeah. So when we ask the person, you have flashbacks, that's a part of the dissociative part of that. Okay. So when you ask the question about the PTSD, anyone use this type of screen when you are evaluating a patient with PTSD? Okay. It is helpful. And if you ask the person just these simple questions, what is the worst thing that ever happened to you? Instead of asking, have you been abused? Okay. So you ask in a simple way, what is the worst thing that ever happened to you? So give the person to describe in their own words what happened. Then, how did you react when it happened? You remember this was from the DSM-4, that's the reason we want to find, but still it's going to be helpful. How did you react when that happened? Then the memories of that still bothers you? Or did you get over it? Do you avoid the situation that might remind you of it? Have your relationship suffered because of it? Have you become more nervous since then, since that happened? It is hard for you to relax because of it. See, if you ask these questions, it will bring you the answer a person has from all those 4 or 5 clusters. Okay. So if you can have this screen and you can give the patient even to fill that before you see them. It takes few minutes, rather than you asking it. If you want to ask, that's fine. Or you can, in your office, you can have this screen and you can just give the patient to fill it. Okay. So that will be helpful. So that's one screen. But every person is busy. Some people can't even use that screen. But sometimes even if you ask about the trauma, some people don't want to tell you. They don't want to talk about it. That is the biggest part. They do not want to talk about what happened. And is there any other screen which can be helpful? This is a well-documented screen. And in the primary care offices, it has a lot of high sensitivity and specificity. And if you look at, it's a very simple screen. It's only 4 items. And it does not even ask the patient whether you ever have a traumatic event. Ask the yes and no question in the last month, like nightmares. Do you have nightmares? Do you have any intrusive thoughts? You are on guard or easily startled or feeling detached. So the yes question, if you have cut-off score of 3, if you get score of 3, you are basically dealing with PTSD. Okay? If you look at the sensitivity, it's in women is 70%, men 94%. Specificity, women 84, men 92. So these 2 simple screens can be helpful in the diagnosis of PTSD. So you can use either the first one or the second one based on the time you have, or you can use both if you want. That can be helpful in diagnosing a PTSD. So what happened to the person who has PTSD? So we did discuss about, about 30% of the patient have the PTSD chronically. And right at the time of 3 months after the person gets the trauma and have the PTSD symptoms, almost about 50% are getting better. And then about 30% it stay for years. Okay. So any question about the diagnosis or the screens? Okay. Let's talk about the treatment for the PTSD. So why the people are resistant to get the help? Okay. Sometimes it's hard because people expect to be able to handle this event on their own. Okay. People may blame themselves for what happened. Okay. So somebody who may have gone through the rape may blame themselves. So maybe I shouldn't have gone there. Maybe I put myself in that situation. Maybe I shouldn't have a drink or something like that. So it is, rather than processing it, what happened, it is blaming self. Or this experience is too painful to discuss. And some people avoid the event altogether. Okay. And it makes person isolated, making it hard to get any help. And many times people don't even make the connection what happened with the event and what they are experiencing. And sometimes they have more than one disorder. They have comorbid disorders, anxiety and substance abuse. Do you see patients like this in your practice? Right? Yeah. So you see where the person is. Basically, it brings all kind of things. It can sometimes bring shame, guilt type of feeling, and blaming themselves rather than putting what really has caused all this. And many times it's comorbid with something else. Almost 88% of the men and 79% of the women who have PTSD, they also meet the criteria for some other psychiatric disorder. In men, it's basically substance abuse is the common one. Then major depression and the conduct disorder can be part of it. In women, it's mainly the anxiety disorder, major depression, but can be substance abuse also. So when you have a person with these type of comorbidity, so PTSD sometimes is hard to be recognized because person is focused either on that or when we don't have much time, we also focus on the imminent things. And then you have the other part where the person doesn't want to talk about it, they are blaming themselves, so they don't, they can't express themselves.
Did you put borderline personality in there?
And here?
Borderline personality.
What it is, if you have, what happened with the trauma? The symptom which it produced, right? So it's going to, the trauma is going to affect the personality. The first part is your own sense or your own security is lost, and you're going to have difficulty to trust anybody. So, if you look at the rape, it happened many times with the person you already know, and then if you can't trust that person, that's the one you are trusting, then it's going to affect your personality. So there is difficulty to trust. There is a persistent sense of shame person have after the trauma sometimes. It affects the relationship, and it affects the mood. And sometimes these moods, they look like borderline personality disorder. But remember, borderline personality disorder is persistent and pervasive. It starts to present in adolescence, even though it may not be diagnosed, but you start to experience that. You suddenly don't develop a borderline personality at the age of 40 or 30 or something like that.
While you're on that personality disorder, I went to a workshop in DC a few years ago, and I met some social workers that are working with people that have borderline personality,
Right.
and they said that 90% of their clients had been sexually abused as young people or physically abused by their fathers or stepfathers. So they were defining them as personality disorder back then, but maybe it was PTSD.
Right. Many times in the patients with the personality disorder, if you evaluate them, you're going to find the PTSD. And that part is true. If you trace it back, many times there is a history of physical, emotional, sexual abuse as a child. And if as a child you develop that, you are going through the sexual, physical, emotional abuse, see how it's going to affect the trust with the caregivers and the providers, who are providing the services at that time. But the part of that is, if the people who are abusing you, whether it's the parent, foster parents, or somebody else, their interest is to keep you not to talk about it. And if you don't talk about it, where are you going to express all this? Who did a lot of work on the borderline personality disorder, other than medication, other than psychodynamic and the psychoanalytical stuff, is Marshall Linehan. And if you look at this treatment which was developed out of this, DBT, and which has been helpful with the borderline. And if you look at anyone know the Marshall Linehan life history? Okay. So see what she has gone herself as an adolescent. And here is a person who gone through all this kind of experience as an adolescent. Then being in various type of settings, then suddenly trying to pull herself together and to do the PhD and then develop this DBT, which has been helpful to so many people. It is the interest of the people who are abusing, not let you express or explain anything. So it's hard if you don't get the treatment to begin with, and then later on, it's hard to be, with type of the personality traits you have, it's hard to express. But again, it's unrecognized, undertreated PTSD. It will be good to evaluate in the patient with borderline personality disorder. Is this a PTSD? What else we can do? Or it affects the prefrontal cortex, which we talked about that. And that can lead to the impulsivity, poor planning, and judgment that change the personality of that person. That trauma which happened has caused these changes which we talked about, the hippocampus, the amygdala, and the prefrontal cortex. And it lead to this, and then person continue to act with that. That becomes the part of the personality. So what happened? We talked about some of this. What happened during the traumatic event? There is an increase in the norepinephrine. And what happened with the norepinephrine? If it's increased, it's going to mobilize the fear. It's going to increase the flight response and activate the sympathetic system, and it lead to the consolidating those memories which we talked about, the hippocampus. If it's too much, the person have this: hypervigilance, autonomic arousal, flashbacks, intrusive memories. Okay. So what can we do about this? We already talked about the propranolol. The other medicine which has been extensively studied in PTSD is prazosin. Prazosin. We'll talk a little bit about that medicine when we go to the medical treatment. And it's again to cut down this norepinephrine from the excess. So serotonin, if it's a less, it lead to things like this: aggression, violence, impulsivity, depression, anxiety. So even the people who commit suicide, if you look at their, in the postmortem, you look at their serotonin level, it's way less in the CSF. So all these studies are well documented, and basically less of serotonin and the excess of norepinephrine. That's what many patients will say, chemical imbalance. So we talked about the risk factor, neurobiology, we talked about the diagnosis. So what type of treatment one can offer? So it can be the individual therapy, it can be the group, it can be the medications. So we'll talk briefly with all of them. So again, I will just go over briefly because we don't have time, but you can spend the whole 1 hour on any one of them. Any one of you do either this exposure therapy or cognitive processing therapy or anxiety management. Yeah. So these are effective. These and many patients can be helped with that. Just managing the anxiety. There are simple things one can do. You can even if you can go to the exercise, that can help with the anxiety. So what happened with the exercise? This VGF which we talked about, vascular growth factor, with the exercise, that level increase of the VGF. Okay. So what VGF does, it leads to the neurogenesis which we were talking about. So all those dendrites, they start to produce those spines. Okay. So just doing the exercise daily can lead to that. Meditation can be helpful. So, but to work through this like cognitive processing therapy, these are the thoughts, so the people don't want to talk about it. So how you can access to it? So you have to find some way to manage the anxiety. Those are various relaxation techniques one have to use, or you have to go through like a graded exposure. You have to work through those. But all these things are helpful. Then there are many other treatments which have been very helpful with the PTSD. One of that is EMDR. And we have our colleagues here who do the EMDR. And it has been found very helpful. You want to say one word or 2 words? Or the,
I use it a lot, and I don't only use it for PTSD, any kind of trauma, irrational fears, beliefs. If you go back to that particular incident and you're able to put it in perspective and move it, I guess, from to a higher reasoning level, then that really is very effective.
That's true. Again, anytime we talked about Marsha Linehan when she developed DBT, same when this EMDR was developed, and same the people were remembering those things. And when those thoughts were coming, their eyes were moving. So that's where they got the idea themselves. Maybe can we do something like that with we ask the person to move those eyes and then talk about it. So is this just a distressing, is that distracting the patient to something else? So they, their inhibition gets less, so they can, talk about it. So, or is there something underlying going on neurochemically, and the person is a little bit more relaxed and can talk about it. Remember those things which we talked about, neuropeptide Y and all those? So sometimes when you do these kind of things, it increases the levels of those, and it can lead to the anti-anxiety type of effect, anti-stress. So the person can talk about these things. So it is helpful. Same thing, hypnotherapy, psychodynamic and expressive therapies have been helpful. And so main thing is to recognize the person and then work with the patient. So it's going to be sometimes a challenge for both patient and the therapist.
So is it really recognized that the dog therapy would really help a lot of these people because it would help to ease the anxiety, give them a feeling of safety
Right.
and trust? They have some, so I mean, is this like a recognized therapy?
There is a lot of research. There are a few studies came in the last 2 weeks on this hormone called oxytocin. Okay. And you know what oxytocin is? It's called love hormone. Okay. Bonding hormone or love hormone. So when you get with this type of treatments where you have some trusting, relationship with a dog or a horse, and then during that time, that oxytocin starts to increase, and that can be helpful in that part. Okay. Yeah.
You said something about VSTAR. Can you go a little, when would you use that as opposed to an SSRI or a good PTSD? VSTAR?
Those part we'll talk about in a minute when we go into the medication part. Okay. Okay. Let's move to the medication part. Okay. So let me see if I can find a marker. Let me see. Everybody heard this project, right? And these were the old medicine tricyclics. And they were like the doxepin, Elavil, imipramine, those type of medicines. But mainly what they do, we already talked about these norepinephrine. We talked about, it comes from this area called locus coeruleus. Then it goes to the different parts. So axon, when they start in the locus coeruleus, they go to the different parts. And then they interact with the next set of the neurons. And the only way they communicate is through these chemicals, either norepinephrine or the serotonin one. They come from the Raphe nuclei. That's the one we talked about. And what happened is, from the presynaptic neurons, norepinephrine is released, and then it acts on the postsynaptic receptors. The rest go back to the neuron, which is stored in this chemical. It cannot stay either here or it cannot stay without this vesicle, otherwise it will be metabolized. So the moment it goes back, then it goes back to the vesicles, and the next impulse comes, then it's released. Same thing is with the serotonin. It's released, then it goes back like that. So what happened is, in the case of the PTSD, let's say norepinephrine, right at the time of the trauma or person is experiencing these memories or these events or these places, they increase the level of norepinephrine. So how can you block it? You can do it presynaptically. If you block it presynaptically, it cuts down the release of the norepinephrine. It's like a brake, like putting a brake on the neurons, don't release it as much. Or you can block in the postsynaptic. So medicine like propranolol, they block it here in the postsynaptic. It's the beta blocker, and it blocks the effect on the beta blockers. Or you can give clonidine. Have you heard clonidine in the ADHD? Right, some kids will be taking it. That is the theory behind it. So it will block here, so it's not released as much here. Okay. So that is the role of that medicine. So the role of the serotonin is the same way. You can release it here, and then it acts on the postsynaptically, or you can block it here. It doesn't go back up. So what antidepressants like Prozac do? They are called SSRI. They only work on the serotonin receptors. And those medicines are like Prozac, Zoloft, Lexapro, Celexa. They are all SSRI. They will all of them will do. What happened in the serotonin? Remember we talked about there is a less serotonin, and how you can increase the serotonin. You have to block it here, or you make the neuron release more of the serotonin. Okay. To block it here, you give medicine like Prozac, they block this receptor, and then it prevents it going back upwards. Okay. Or you can give a medicine which acts on the presynaptic receptor here. It's called presynaptic agonist, and that's what that medicine Buspar is. And if you give the Buspar on serotonin, it's like an accelerator. It's not a brake. It is you put your foot on an accelerator. So what that does is it makes these vesicles to release the serotonin in the synapse. So either you can give the accelerator like the Buspar, or you can give an antagonist or a receptor uptake blocker, and that is medicine like Prozac, Zoloft. So in PTSD, there is a role of both. One work on the norepinephrine. You have to cut down the norepinephrine, but you have to increase the serotonin. And the way if you give antidepressant like SNRI, like Cymbalta or the Effexor, they act like this. They act the blocker here, then they block here. So that is a different mechanism of action. So that in the acute state, sometimes increase the norepinephrine. Sometimes that may not be as helpful. So that's the reason sometimes when the people with the panic disorder, anxiety disorder, they take the SSRI, they get worse. Their anxiety actually increase. And that is the reason sometimes we give the person some benzodiazepine like Ativan, Xanax for a limited time. Because in the anxiety disorder, these SSRI, SNRI, they are very, very effective. But they need to be at a higher dose. Like if the person has OCD as a part of the anxiety disorder, they will need the upper end of these medication. The upper end is, let's say, they will need maybe Prozac of 60 milligram or more, or the Zoloft or 200 milligram or more. But even if you give them the first day, even 25 milligram of Zoloft, that might make them more panicky. And main reason for that is it increases these norepinephrine, serotonin. So that is the theory behind it. Or you can give MAO blockers. And it's a monoamine oxidase. What it does is it metabolizes serotonin, 5-HT, or norepinephrine. Or you can block their metabolism. And these medicines, they are like Nardil, or like there is a patch called MSAM. You can put a patch and you can block these. But these medicines were not as popular in the States because you have to watch certain things. You can't eat certain food, you cannot drink certain drinks, or you cannot take so many over-the-counter pills.
I thought that they certainly have their place, but I thought they're almost impossible to get here.
No, it's available.
It is?
It is available. But many people don't want to follow those precautions.
Side effects.
So one side effect is it's the interaction between the drugs, and if that happens, that raises your blood pressure, and person can have a heart attack, stroke, and those kind of things. But in Europe, these medicines are extensively used, and the patients, they follow with all those, even though they eat all kind of cheese, and all that. For them to give it up but they are willing to do it. But in states, these medicines are not used as frequently. It is used mainly for the people who are resistant to the depression or anxiety, who do not tolerate, who do not get any response from the others. So otherwise, there is a medicine called selegiline. It's used in the Parkinsonism for many years and is still being used. And that medicine was basically looked at that, then it came as a patch, MSM. And that is very effective for the people with the resistant type of depressions. So we talked about the SSRIs. These are the medicine we talked about. Basically, it affects the concentration and activity at the neurotransmitter serotonin. That's what we talked about. It may, when you have that, may reduce the depression, intrusive, and the avoidant type of symptoms, anger, explosive outburst, hyperarousal symptom, numbing, etc. And FDA has approved all these medicines for the anxiety disorders. Remember, the PTSD was a part of the anxiety disorders. Now it's a trauma-related stress disorder. So they are approved for the PTSD and are effective in these type of symptomatology. Again, remember that we talked about our goal is to protect this hippocampus and protect this anterior cingulate cortex. And how we can do it, BDNF. This is what we talked a little bit earlier, brain-derived neurotrophic factor. And it's a protein. It's implicated in the neural cell growth and differentiations. Okay. So remember, as the child starts to develop, all cells are same, right? And then we have so many chromosomes. We have like 30,000 genes. And then the genes make them to express. You become liver cells, you become the brain cells, you become this cell. And once it's expressed, then that's the cell it becomes. But throughout life, the genes are expressing themselves. Okay. And you can change some of those things with this type of thing. And BDNF it's part of the body, brain-derived neurotrophic factor, which help in the neurogenesis. And how we can do it? So say this brain-derived neurotrophic factor act on the receptors, and it lead to all the changes, and it lead to ultimately short and the long-term regulation of the neural functions. On the other way to do it, if you don't have, it's hard to get BDNF. But you can do the 5-HT, and that is serotonin. You can work on these receptors. It ultimately leads to the same kind of changes or through the same kind of channels through the protein transcription factor, leading to this short and long-term regulation of the neural functions. So that was the rationale for those studies when they gave these medication long-term for the patients who had trauma and have not developed the symptoms to protect these neurons. So these medicines can be very effective. But what happened with our patients? They start taking it, and how many people get their second prescription filled? Not many, right? And if they take it, how many stay on it for 3 to 6 months? Not many. So it is the education which need to be provided to the patient. Look, this is what it is. These are the areas which can have long-term consequences. And you need to stay on your medicine long-term. And then at the same time, you go through these psychotherapies and you work through some other things. And ultimately, you can come off this medication. There are other ways to, the fear is a learned thing. And how you can unlearn that fear. Okay. So medicines alone can't do all this. So remember, there are positive symptoms, there are negative symptoms. And it's no matter, you can pick up any disorder in psychiatry. you will have negative symptoms, positive symptoms. If it's a, let's say if it's schizophrenia, what are the positive symptoms in schizophrenia? It's the hallucination, right? It's the delusions, right? What are the negative symptoms? Right? Right. So negative symptoms, and then same way in PTSD, what are the positive symptoms? And what are the negative symptoms? The negative symptoms are like the avoidance type of symptoms, right? And some of those can be like all this cognitive way of functioning. And that cognitive way of functioning is like blaming yourself, right? Or you feel like that I can't do anything, my life is not going to go anywhere. All these negative cognition, medicine may not make whole lot changes. So that's the way when the person go through the psychotherapy, you can change those cognitive functioning, and then maybe down the road you may not need medication. But it's part of the education of the patients. This is what it is. These are the consequences of what you have. This is what you have to do to protect underlying these neurons, and you have to learn some other way to do things. This is the medicine which I was talking about, prazosin. Anybody heard about this medicine? Those who work in the PA have heard about it. But basically what it is, it's a blood pressure medicine. And the person who have nightmares, flashbacks, intrusive memories, the prazosin can be very, very helpful. And the way we do here is we will start them at 1 milligram, because we want to see if they can tolerate it, that their blood pressure doesn't drop that much. If the blood pressure stays in the normal range, then you can increase it all the way up to 15 milligram. So remember this alpha 1, these are the receptors in the norepinephrine. We talked about alpha and the beta receptors. So this medicine work on the postsynaptic alpha 1 receptor and work as an antagonist. And these are widely distributed in the brain, including the area of the amygdala and the hippocampus. And they modulate the sleep and the startle response. Remember in the PTSD, there is a part with the sleep which is in nightmares and interfere with that, part with the startle response. Yeah, that
problem with giving it to elderly?
Right.
Is there any problem?
No, there is no problem in the elderly, as long as their blood pressure can. The main thing is, in the elderly, the biggest concern is fall, and you don't want to lower their blood pressure too low, where they can have this dizziness and they fall, and that has its own consequences. So as long as their blood pressure is stable, they are not having the dizziness. There is no problem with that. So there are all kinds of studies have been done, and the adverse effect is, basically it can be syncope, dizziness, drowsiness, and some tiredness to begin with. So it is a very effective drug, and can be added along with the SSRIs. So let's talk a little bit about the kids. Have you seen any children with PTSD? Anybody? Right? Okay. So are there any medicines approved? There are some medicines which are approved for the PTSD in the kids. And the symptoms are basically the same from 6 age onwards in the PTSD. Under the age of 6, there are minor variations, but basically they are the same type of symptoms. There are various kinds of therapies are tried in the kids, but the main one which has a lot of evidence, it's evidence-based, is called trauma-focused cognitive behavioral therapy. Anybody do trauma-focused cognitive behavioral therapy? Yeah. So you do with both like a parent module and the children modules, right? And it is very, very effective. And again, we don't have time to go into the details about it, but trauma-focused cognitive behavioral therapy is very, very effective. Yes.
Aren't children really being overdiagnosed now with the bipolar, and they're being put on Seroquel, things like that, when it could really be PTSD?
That part is true. You know, there is so much controversy about the bipolar disorder in the kids, and in the DSM-5, there is a new diagnosis. It's called disruptive mood regulation disorder. Okay, so that the kids are not diagnosed with that. But the main thing is in many of these children, they are diagnosed based on some of the symptoms which could be just a part of the PTSD, or they are part of this combination of PTSD, oppositional defiant disorder, and they are misdiagnosed. So it could be part of just PTSD. So just concluding all this, most of our patients are suffering from the unrecognized trauma. Trauma is very common. Okay. They most likely will not tell us unless we ask the right questions. And that also at the right time, in the right way. Okay. Remember those screens which we talked about, they can be helpful. Those 4-item screens which we talked about and the other screen for the PTSD, they can be very helpful. And if they don't have the words to tell us, we have to help them to find the words. And many of the patients with PTSD have this thing, alexithymia. They have difficulty to describe their feeling. They have difficulty to describe in the words what they feel. So when they are ready to tell us their stories, then we need to be willing to hear them. Then it's not just saying immediately, I'm sorry about all this, what happened to you. It is hearing about all this. And it's a hearing about, how it has changed their life, how it has changed their relationship, how it has changed their functioning, and then helping them with the medications, combination of medicines, and all that. So with all this, I will stop. So thanks for paying attention. And any other questions, comments?